for today's lecture on diabetes mellitus. My name is Stacy Norrell, and today we're going to be discussing diabetes mellitus, oral health implications, and dental hygiene patient management. First, let's discuss what is diabetes. Diabetes mellitus is actually a group of metabolic diseases characterized by high blood glucose levels and the inability to either produce or use insulin. We're going to primarily focus on the differences between type 1 and type 2 diabetes. We'll also touch on prediabetes and gestational diabetes. Now, you may have also heard of diabetes insipidus. That's actually a very rare disorder in which the body cannot regulate how it handles fluids. So that's a disorder of salt and water metabolism. Patients with diabetes insipidus do have some of the same symptoms as a diabetes mellitus patient, in which they have extreme thirst and heavy urination. But even though they share a few of the same symptoms, the two diseases are completely different. So let's take a look at the prevalence of diabetes here in America. According to the CDC, approximately 30 million Americans, or 9% of the population, have some form of diabetes. The ADA is predicting that 87 million will be type 2 diabetic by the year 2050. We are seeing a drastic increase each year in the number of diabetic cases. If the current trend continues, then the CDC is also predicting by 2050 that 1 in 3 Americans will be diabetic or pre-diabetic. Diabetes is also the 7th most common cause of death in the United States. This is falling behind heart disease, stroke, and cancer, but continues to be on the rise. So why do you think we are seeing such a drastic increase in the cases of diabetes here in the U.S.? So type 2 diabetes is especially on the rise. Here in the United States, the American lifestyle and diet tend to put us at an increased risk for type 2 diabetes. Fortunately, this is something we have control over. Unlike type 1 diabetes, which is an autoimmune disease, type 2 can be prevented by some lifestyle changes. So everything in moderation. Before we dig deeper into the differences between type 1 and type 2 diabetes, I want to briefly focus on the pathophysiology of diabetes. One important key player is insulin. Insulin is a hormone that's made by our pancreas that allows our body to use glucose from the carbohydrates in the food that we eat for energy or to store for future use. Insulin keeps our blood sugar level from getting too high or too low. So what happens is after we eat, our stomach absorbs the food. Glucose is released into the bloodstream, but the cells are not able to directly accept the glucose for energy without the help of insulin. So after we eat and our blood sugar level rises, the beta cells in our pancreas are signaled to release insulin into the bloodstream. And then the insulin attaches to the glucose and signals the cells to absorb the sugar from the bloodstream. So they kind of act like a key receptor in allowing the sugar to enter from the blood into the cell so that we can use it for energy. If you have more sugar in your body than it needs, insulin helps store the sugar in your liver and then releases it when your blood sugar level is low or when you need more sugar. So between meals, or if you're working out and your body needs more energy, that's when more insulin is released. Insulin helps balance out our blood sugar levels and helps keep them at a normal range in a healthy patient. If our body does not produce enough insulin, or if our cells are resistant to the effects of insulin, you may end up developing hyperglycemia, which can cause long-term complications if the blood glucose levels stay elevated for any significant period of time. Now let's take a look at the pancreas and action of insulin. So insulin is released by the beta cells in the islets of Langerhans in response to food. So its role is to lower glucose levels in the bloodstream and promote the storage of glucose in fat, muscle, liver, and other body tissues. So we can see in the healthy pancreas here that insulin has been secreted into the bloodstream and it's going to attach to the glucose. And then the receptor on the cell then can allow the glucose into the cell for energy. In the case of a type 1 diabetic, the pancreas is no longer producing insulin. This is an autoimmune disease in which our body attacks the beta cells of the pancreas. So no insulin or very little insulin is produced. Type 1 diabetics are always insulin dependent. With type 2 diabetics, you can see that the pancreas is producing some insulin. It may be sporadic. They may have a reduction in insulin, or there may even be a receptor defect in which the body cells are able to absorb some of the glucose for energy, but not all. This diagram shows 3 different examples of progression of disease from normal to pre-diabetic to diabetes. The A1C exam is a blood draw that's done in your physician's office that gives you the average blood glucose levels over the last 3 months. The fasting plasma glucose is a blood draw in your physician's office after you've been fasting for at least 8 hours. And the oral glucose tolerance test is done in your physician's office after you have drank 75 grams of glucose that's been dissolved in water, and then they draw your blood 2 hours later to see what your glucose levels are. These tests each have distinct diagnostic thresholds for the diagnosis. I always do ask my patients who already know they're diabetic if they do remember what their last A1C was. Patients may not always know this information, but if they do, I like to document that in their chart. It's also important on your diabetic patients or patients that are exhibiting any of the symptoms to do a glucose monitoring exam real quick in the office. Anything over 200 milligrams per deciliter of glucose puts the patient at a higher risk for infection and potentially slower healing from dental hygiene care. So there's 3 cardinal signs for diabetes: polyuria, which is frequent urination; polydipsia, excessive thirst; and polyphagia, excessive hunger. If your patient has checked no to having a diagnosis of diabetes on their medical history, but they have checked yes on frequent urination or excessive thirst, then that's a sign for us to go ahead and take a quick glucose reading chairside to see where they are ranging. If they are within normal range, it could be that they're just drinking a lot of water, so they have to urinate frequently. They may be on medication causing dry mouth, which is making them more thirsty. Or it could be that if their glucose levels are above normal range, that they do not know at this point that they are diabetic, and we would want to refer them to their physician for further testing. If they fall above our range of 200 or acceptable range of 200 milligrams per deciliter, we would not be able to see them in our clinic. We would want to refer them for a physician consultation. Though it makes sense that if you're drinking more water, you're going to need to urinate more frequently, with diabetes, it's actually kind of backwards on the causes. So what's going on is we know that without insulin, the glucose that's derived from the carbohydrates that we're eating cannot be used or stored. So they're just floating around in the blood. And when the blood glucose level rises to more than 150 milligrams per deciliter, the kidney tubules become incapable of resorption. So what happens then is that the glucose is in the urine, which is glucosuria, and it's taken with it large amounts of fluid. So that's why they have larger volumes of urine. This leads to dehydration, which causes the patients to be very thirsty. So it's just a cycle that keeps repeating itself until the glucose levels are under control. So when a patient has defective carbohydrate metabolism, as with diabetes, the body cells are not able to use the glucose for energy. So the cells think they're starving. This makes the patients feel hungry all the time and leads to excessive eating. First, we're going to take a look at type 1 diabetes. Type 1 diabetes is the least common of the two. It only accounts for about 5% of the total diabetic population. It is an autoimmune disease in which our body's immune system has attacked the beta cells of the pancreas, and so our pancreas is no longer producing insulin at all. Type 1 diabetics will always be insulin dependent. These patients are typically diagnosed at a younger age, and they're typically slim. Weight is not a factor with type 1 diabetes. These patients will usually exhibit the cardinal signs of diabetes: unexplained weight loss, frequent urination, excessive thirst, polyphagia. They may be very weak, tired a lot. I do have a friend whose child was diagnosed as type 1 diabetic, and one of the first things she had noticed was that he was exhausted every day after school and wanted to sleep a lot, which was not like him because he had been a very active athlete. Then she started to notice that he was constantly thirsty. He was eating a lot. He was a growing boy, but he was not gaining weight. And then with the constant fatigue, she ended up taking him to the doctor for blood work and found out that indeed he was type 1 diabetic. This completely changed their life overnight and has affected them, especially him, for the rest of his life. Type 1 diabetics will be insulin dependent until they find a cure for diabetes for the rest of their lives. Type 1 diabetics often wear an insulin pump. This is basically a small computerized device that kind of mimics the way the human pancreas works, in that it will deliver small doses of short-acting insulin continuously if needed. And it also is used to deliver variable amounts of insulin when a meal is eaten. So you can keep track of your carbs, your glucose levels, add insulin as needed to keep your glucose levels regulated. There's also an app that attaches, that syncs with the insulin pump itself. This is very helpful for parents whose children, they can monitor even while they're at school or when they're asleep. Glucose levels can spike even when a child is sleeping. And so then this can alert the parent and they can go administer insulin via the pump. They also make little pouches that you can put the insulin pump in, so children are still able to swim and have fun with their friends. Now let's take a look at type 2 diabetes. This is the most common form of diabetes mellitus and accounts for about 90 to 95% of the diabetic population. Type 2 diabetes differs from type 1 in several aspects. The symptoms for type 2 diabetes come on very slowly. This is not something that's going to be an abrupt change to a patient, to the way they feel. A patient may be pre-diabetic or diabetic for several months or several years before an actual diagnosis. So from the dental hygiene standpoint, again, if the patient has marked yes on their medical history for excessive thirst or urination, we would want to do a glucose monitoring test. Or if the patient is obese, that is a risk factor for developing type 2 diabetes, along with hypertension and sedentary lifestyle. We do ask the patients about their eating habits when it comes to doing their risk assessment for caries. But as far as for diabetes, we just do the glucose monitoring. If the patient has confirmed they have a diagnosis of diabetes, if they have the symptoms, or if the patient is obese with a high BMI. Type 2 diabetics are at risk for developing macrovascular and microvascular complications. This risk is very high, especially if the patient is not keeping their diabetes under control. Unlike with type 1 diabetics, the weight loss is very uncommon. So with a type 1 diabetic, they may have some sudden unexplained weight loss due to the ketones in their blood. But with type 2 diabetes, this does not frequently happen. Type 2 diabetics do often respond to weight reduction, changes in their dietary habits and sedentary lifestyles. So many type 2 diabetics are able to keep their glucose levels under control just by making lifestyle changes. About 40% of type 2 diabetics, though, do require insulin or some form of pharmacologic help to maintain healthy glucose levels. Gestational diabetes occurs in about 4% of pregnancies. Now, it's important to note that if your patient is already type 1 or type 2 diabetic and they become pregnant, They're still diabetic. That doesn't mean they have gestational diabetes. Gestational diabetes is onset during pregnancy only. The pregnancy hormones automatically have a normal anti insulin effect on a patient. So, between weeks 24 and 28, typically, the OB will have the patients do an oral glucose test. You drink the glucose drink, and 2 hours later, you have your blood drawn. If there is an excess amount of glucose in your blood, then the patient is considered to have gestational diabetes, which can cause some risk to the mother and an unborn child. These mothers are at a higher risk for developing diabetes after pregnancy. They're also at a higher risk for C-section and delivering large babies. After the woman has delivered, about 6 weeks after the pregnancy, they're going to do another blood test on the patient to see if the patient has returned to normal glucose levels. So the patient would be reclassified as either normal, having pre-diabetes, or being diabetic. But gestational diabetes typically goes away once the baby is born. This chart gives you a breakdown of comparison between type 1, type 2, and gestational diabetes. We have covered all this information in the previous slide, but this gives you a nice layout on everything side by side. The patients with type 1 or type 2 diabetes often have a tendency for severe long-term complications with both the microvascular and macrovascular system. These patients are at a higher risk for heart attack, stroke, eye problems, including glaucoma or even blindness. More than 50% of diabetics have issues with neuropathy, typically in the feet or legs. You may have heard about diabetic wounds that won't heal. In most extreme form, sometimes amputation of a limb may occur because of the poor circulation or infections that keep occurring when the patients have neuropathy. For type 1 diabetics, the most predominant issues they have would be with eyes and kidneys. And then with type 2 diabetics, they tend to have the higher risk for the heart attack and stroke. But remember, with type 2 diabetes, one of the risk factors is obesity. So in itself, obesity is a risk factor for heart disease. So those kind of go hand in hand. Neuropathy does, however, occur with both type 1 and type 2 diabetics. So how does seeing a diabetic patient affect dental hygiene care? Well, we know that a patient that has uncontrolled diabetes is at a higher risk for developing infections. The glucose levels can weaken the patient's immune system if they're too high for an extended period of time. These patients may also have nerve damage and reduced blood flow. This is going to also increase their body's vulnerability to infection, and their wounds will heal much slower. So we know as hygienists we're stirring up millions of bacteria in the patient's mouth, and especially if they have active periodontal disease, which is already an infection, we don't want to create a situation in which they're not going to heal properly from dental hygiene care. So it's important for us to make sure the patient's glucose level is within normal range before we begin treatment. If it is not, it would be important to refer them for a physician consultation before we begin. In our clinic, we do not see patients whose glucose level at the time they're in our office is over 200 milligrams per deciliter. That's the threshold that throws them at an increased risk for infection. It's also important as dental hygienists for us to be able to recognize and treat diabetic emergencies. Obviously, our goal is prevention, and the best thing we can do to prevent a diabetic emergency in the clinic is to take a very thorough medical history. And if the patient is diabetic, then we want to make sure their glucose level is within a healthy range. If the patient does start feeling ill while they're in your chair, it's important for you to know the emergency protocol of your practice. So know exactly what code needs to be called. You never leave your patient's side. You want to get someone close to you to go get the glucose gel or juice or whatever you have on hand. A fast-acting glucose gel is very common to have in the dental office. It has a longer shelf life than, say, having juice or some form of carbohydrate on hand. This can be put underneath the patient's tongue, directly on their tongue. If they don't feel like they can swallow, you can actually just rub it on the buccal mucosa and it will absorb. If the patient completely passes out, you would need an injection of glucagon to get some glucose into their system quickly. Most dental offices may not have this on hand. This would be when the EMS system would be activated, and paramedics do carry this with them. As we discussed earlier, patients that have uncontrolled diabetes have a tendency to heal slowly. High levels of blood glucose caused by diabetes over time can cause neuropathy and lead to poor circulation. If a patient has poor blood circulation, the blood is not able to get to the areas that need healing. So in a minute, we're going to take a look at the relationship between active periodontitis and diabetes being uncontrolled. Though one doesn't necessarily cause the other, the relationship is bidirectional. As you can see in this image, it just shows the normal foot with good blood circulation, the diabetic foot starting to show a decreased blood supply due to poor circulation, and then the diabetic foot with the ulcers. These ulcers often on these feet do not heal and can lead to amputation. The two diabetic emergencies that you may encounter in the dental hygiene clinic would be hypoglycemia, which is when the blood glucose concentration drops below 70. The patients will start to feel kind of clammy and weak, maybe a little shaky and dizzy. Typically, they feel this coming on and can warn you. You would want to stop all treatment, and this is when you would need the glucose gel or glucagon like we just described in the previous slides. Another potential emergency, which again we're going to avoid by taking a very thorough medical history and knowing our patient's glucose level, would be ketoacidotic hyperglycemia. This can lead to a diabetic coma, which could result in death. So if our muscle cells are starved for energy, basically we have all this glucose in our body, but it's not getting into the cells, so our cells are not having the energy they need, our body's going to respond by breaking down fat stores. So that process forms toxic acids known as ketones. So if you have ketones, which can be measured in blood or urine, and high blood sugar, that condition is called diabetic ketoacidosis. If this condition is left untreated, it can lead to a diabetic coma. This can occur when glucose levels rise and maintain above 400 milligrams per deciliter. If we see a patient in clinic and as part of their medical history, we're taking their glucose level and they're above 400, we recommend they go see their physician immediately. Diabetic ketoacidosis is most common in type 1 diabetics, but can sometimes occur in type 2 diabetes and even gestational diabetes. They may have that Kussmaul, that labored breathing, and a fruity breath smell. If a patient starts exhibiting these symptoms, these are pretty textbook for low glucose, hypoglycemia. What I have experienced with these patients would be that they start feeling this cold sweat come on and they're a little dizzy, just kind of a feeling like they may pass out and want to lay down. With the glucose gel, they start feeling better almost immediately. It really gets into their blood system quickly. With hyperglycemia, your patient may feel very fatigued, may have some dizziness, blurry vision. They're going to have the textbook signs of excessive thirst. They may feel like they're going to throw up, and they may have very fruity breath. Again, this is with glucose levels that are maintaining over 400 milligrams per deciliter. The leading causes of death with type 1 diabetics is renal failure, and type 2 diabetics is heart attack. Disease management. One of the most important things a diabetic patient can do is to monitor their glycemic control at home. The over-the-counter glucometers are relatively inexpensive and very simple to use. Diabetic care is very individualized, so how often a patient needs to do this throughout the day would depend on the recommendations made by their physician. We do take glucose reading at the beginning of an appointment for our diabetic patients so we can find out what their status is at that moment. It's also important for them to be seeing their physician every 3 months to have their A1C checked. So while the glucometer will give us an idea of what their glucose level is at that moment, the A1C reading will give them an overall view of their glycemic control over the previous 3 months. Lifestyle change is really the hallmark of care for type 2 diabetic patients. Remember that obesity is a risk factor for diabetes, and many of our type 2 diabetics are obese. So changing lifestyle to a more active way of life and reducing carbohydrate intakes, switching from white bread to whole grains, no white rice, eating brown rice, just making dietary changes can actually help keep their glucose levels under control and possibly even allow them to not take any medication. It's great to see our diabetics who are able to control their glucose levels just with diet and exercise. Type 1 diabetics often have to count their carbohydrates and balance that with the amount of insulin that they are using through their pump to make sure that their glucose levels stay within a normal range. As far as insulin therapy, remember that type 1 diabetics are always going to be insulin dependent because their pancreas is not secreting insulin at all. Oral hypoglycemic agents are only used for type 2 diabetes. The medication that I want you to remember is metformin. That's going to be the most common therapy that you're going to see your type 2 diabetic patients taking. What metformin does is decreases the amount of glucose secreted by the liver. It decreases intestinal glucose absorption and increases insulin action. Hypoglycemia is not a side effect of this drug. And the main contraindication that I want you to remember is that people with reduced kidney function cannot take metformin. The dental hygiene process of care. So when our patients come in and they've got well-controlled diabetes, we take their glucose level and everything is within normal range, we can proceed with care as we would any healthy patient, and we would expect the same results from the care they receive with proper healing. If the patient has an oral infection or their glycemic control is not within normal limits, we would need to consult with that patient's physician before proceeding. If a patient has poor diabetic control, then periodontal disease is going to progress at a faster rate than it would in a healthy patient. The patients aren't able to heal correctly, and so the tissue remains inflamed and ulcerated. As with any patient, the process of care begins with the assessment. And one of the most important things we can do to help prevent a medical emergency in the dental chair is to take a very comprehensive and thorough health history. So as part of the health history, the dental hygienist questions the patient on a variety of systemic diseases, one of those being diabetes. As we know with type 2 diabetes that patients may go undiagnosed for years. They may have very few symptoms, or the symptoms may be coming on very slowly and they don't know the difference. So even if the patient selects no for diabetes, but they say yes for excessive thirst or frequent urination, or if the patient has other risk factors such as being obese, the CDC recommends that the dental practice either take glucose there chairside with a glucometer or do an A1C test. My guess would be that most practices don't have the capacity to really do an A1C, but doing a chairside glucose test is very quick and efficient and very inexpensive. This is for the patient safety as well as for the clinician to make sure they're providing the highest standard of care. If the patient knows they're diabetic, then we're still going to take the glucose reading chairside, and you also want to ask questions about if their last A1C, when's the last time they saw their physician, any medications they're taking, the dosages, how often they take them, how often do they monitor their own glucose at home, and any other methods that they're using to control their diabetes. All of this needs to be documented in the patient health history. So even though diabetes and periodontal disease do not necessarily cause the other, they do contribute to the severity. So if you have a patient who has uncontrolled diabetes, they are more likely to have periodontal disease if they do not have optimal home care already. So if there's any sign of disease or inflammation in the oral cavity, that patient with uncontrolled diabetes is going to have a harder time getting that under control. We know from what we've already learned is that they are more susceptible to infection and their wounds heal slower. So when we have a chronic infection like periodontitis, the patient may not heal from that as easily as if their blood glucose levels were under control. Periodontal disease may also make it more difficult for people who have diabetes to control their blood sugar. Because of the infection, the blood sugar levels stay elevated. This really puts dental hygiene at a crossroads because we're not able to safely treat a patient who has uncontrolled diabetes. So say you have a patient whose glucose level is around 300, we know we can't treat them, but when they have active periodontal disease, we also know that's not going to get better until we can treat the periodontal disease. But we can't treat the periodontal disease until they get their diabetes under control. So it becomes very complicated in the way we care for these patients. Patients with uncontrolled diabetes are at risk for oral complications. When you're doing your oral assessment, you're going to be mindful to document and educate the patients on any findings they may have. Patients may have chalosis in the corners of their mouth. They may be experiencing xerostomia, and they have increased glucose in the saliva they do have. Those two things combined put the patient at a higher risk for dental caries. And as we know, uncontrolled glycemic levels do put the patients at a higher risk for periodontal disease, which is much harder to control in diabetic patients. Image A shows a patient whose blood glucose level was above 400 milligrams over deciliters. You can clearly see the ulcerated areas along the gingival margin. Image B was 4 days after insulin therapy. The patient was able to get their glucose level to right at 100 milligrams per deciliter. So you can see just with correct glycemic control, wounds are able to start healing. Dental hygiene diagnosis and care planning is the same with our diabetic patients as it is with all patients in regards to taking the patient's individualized unmet human needs into consideration. For diabetic patients, we want to minimize the stress and anxiety revolving around the appointment. Stress can cause their glucose levels to rise. We want to schedule them mid-morning is typically ideal. It's when their glucose levels are most controlled. We want to encourage them to eat a healthy breakfast before they come in for their appointment. Limit their carbohydrate intake. We don't want our patients to have a Starbucks and donut on the way to the dental office because that's going to spike their glucose when we take it chairside. And remember, anything over 200, even if they just ate, they come in and it's 250 or 300, we're not going to be able to see them. If the patient comes in and does have an elevated glucose level, what we encourage you to do is have this patient walk around for a little bit, get some water. We're going to retake this glucose reading to see if we're trending down. If the patient, for example, has a glucose reading of 210 or 215, and they were really kind of anxious getting there, they're a little nervous, they couldn't find a place to park or whatever, for whatever reason, or if they just had an unhealthy breakfast and their glucose levels are just a little bit above what the limit is for our clinic, we're going to have the patient take some time, calm down. When we retake this glucose level 15 minutes later, and now they're at 200, 199, but we can tell that they're trending down, Typically, we will go ahead and proceed with care at that time, maybe starting with the radiograph, something non-invasive to give their glucose a chance to stabilize at that moment. If you, for example, take glucose though when it's running 300, 350, it's not going to come down into an acceptable level in 15 to 20 minutes. So we would encourage those patients to go see their physician and make sure they are self-monitoring at home, taking their medication properly, and taking care of themselves. So implementation is actually very similar to how we would treat all of our healthy patients, because we're not going to be providing care for patients who have uncontrolled diabetes anyhow. So with our patient who has good glycemic control, we will proceed with care as usual, and we should expect results as if they were a healthy patient. So we're going to remove all hard and soft deposits based on this patient's individualized need. So whether that be with ultrasonics or hand instruments or combination of the two, which is definitely my preference, we want to remove all hard and soft deposits on this patient. Stressing optimal oral home care is extremely important with these patients, because we know that with a patient with, especially with uncontrolled diabetes, that they're not going to heal properly. So if the patient starts having some biofilm-induced gingivitis, they're going to have a harder time getting that under control than a healthy patient would. If the patient has periodontitis, it's important that we maintain every 3-month intervals, teaching the patient how to properly care for their health at home using whatever adjunctive therapies are individualized for this patient, and making sure that patients are thoroughly educated on the importance of maintaining optimal oral health to the best of their ability, as well as glycemic control, because if one or the other gets out of control, it's going to exacerbate the seriousness of the other. So if their glycemic control is way out of whack, the periodontal disease is going to progress quicker. They're not going to heal as quickly from infection, and they're going to have a higher speed of clinical attachment loss than a healthy patient would. Local anesthetic. So we want to use our vasoconstrictors with caution. Epinephrine has an effect opposite of insulin and can actually raise a patient's glucose level. So it's important with our patients who have had SRP to make sure they come in for a follow-up visit so we can check to make sure they are healing properly. If the patient is not, and you can tell the healing is delayed, this may indicate that the patient has hyperglycemia. Again, we're taking glucose levels chairside now. This hasn't always been the case, and so now we're able to really know at that moment kind of where they stand. So the delayed wound healing could indicate hyperglycemia, or it could be that they haven't changed their oral home care habits. So we really want to take this time to evaluate and educate the patients. Also, it's a good time to decide, okay, do we need more frequent dental hygiene visits? Basically, how's this patient responding to care? And then, of course, documentation. If it's not documented, it did not happen in dental hygiene. So make sure you are documenting any data you collected. That's going to be their glucose level, what medications they take, how often they take it, what was their last A1C, how are they, are they on any other medications, do they take insulin, everything you can think of regarding that patient's health, our treatment plan, and what recommendations we have made for this patient. Okay, so just some extra info. I know we all have friends who have done the keto diet to try to get their bodies into ketosis. And we're going to talk a little bit about the difference between ketosis and ketoacidosis. Ketoacidosis is extremely dangerous, and it can even cause death. That's when the insulin is down to absolutely zero. Blood sugar levels are extremely high, and there's no insulin there to bring it down. So there's ketones that are released into our blood, and that changes the pH in the body to a very acidic level. This can actually be life-threatening. It's a complication more commonly with type 1 diabetes. But this is when a patient can actually go into a diabetic coma. That's where we talk about the fruity breath smell and the small breathing. Ketoacidosis is very, very dangerous. Ketosis, on the other hand, there's still some insulin in the body. There's a low level of insulin, a low level of sugar. Patients may be fatigued, but if they take some B vitamins and potassium, that usually will counteract the fatigue. So their ketones are low. They're not non-existent. They're not zero, but they've gotten their ketones very low. And so that has a mild fat burning effect. So these two are not the same. Ketosis occurs when the body starts burning fat instead of glucose, so patients are able to lose weight. Thank you for joining me today, and don't forget to like and subscribe our page so you don't miss any future videos.